Okay. So Dr. Dahl attended Creighton University Medical School. She completed an internal medicine residency at Barnes Jewish Hospital, Washington University in St. Louis, Missouri, where she also completed her geriatric fellowship. She worked as a hospitalist physician at Missouri Baptist Medical Center in St. Louis, Missouri, where she started an acute care for the elderly unit. For the last 8 years, she's worked as an outpatient geriatrician at Sanford Health. She's the medical director of Balance and Stability Clinic. She currently serves as clinical assistant professor of geriatrics at UND School of Medicine. She completed the prestigious Tideswell USCF AGS Leadership Program for Emerging Leaders in Geriatrics. Lindsey is a fellow of the American College of Physicians. And we also have, I apologize, Marsha Nygaard. I blanked on that. I apologize. And I will go ahead and let you guys introduce Marsha.
Yes, I'm excited and so thankful that Marsha agreed to do this talk with me. She's bringing a lot of knowledge and expertise that I don't have myself. So she is a graduate of St. Luke's School of Nursing and University of Marion Bismarck. She's been a nurse for 37 years in various critical care units, mostly at Sanford Health in Fargo. And the last 3 years, she's worked as a certified advanced care planning facilitator and assisting patients with advanced care planning documents and implementing the Fargo region advanced care planning initiative. So she brings a lot of great knowledge, and I just thank you for being here with me to talk about the M of what matters most. And so this is often a difficult conversation to have with people, and so hopefully we will, let's see if I can click, there we go. Hopefully we'll be able to help you understand the difference between the various documents we have, the ACP, the pulse code status, and what those mean. Realize the importance of why it's important to have these conversations, learn tips on navigating how to have these conversations. I'd like to hopefully dig a little bit deeper into how we align care in general with what matters most and what does that mean. And then give you some resources so that you can learn and develop your skills in having these conversations on your own. So I guess I like to start a little bit about talking about, what is death and or what is quality of life, I guess, is the other thing that I think Dr. Miller is talking about in this piece. But B.J. Miller is a palliative care physician in San Francisco, and he runs the Zen Hospice House there, and he's been really vocal. He has a TED Talk that's really good, and he has a documentary about his Zen Hospice House, and he's just a really knowledgeable palliative care physician. He has an interesting story that he talks about in Life Story himself that I think brought him to this place of being a palliative care doc and really thinking about what is life and what is death. And that is when he was 18 years old, he was hanging out with his buddies and they were climbing on a parked bus, but it was one of the electrical buses that runs under the electrical lines. And he talks about how they were climbing up on top and he raised up his hand and he had a metal watch on his wrist. And that metal watch took in the electricity from the lines above and it shot the electricity through his arm and his body and out his legs. And so he had a very long hospitalization with burns and infection and ended up losing one of his arms and both of his legs in this accident. And so, had to go through a lot at a young age and ended up sharing, I think, the things he learned going through that experience to become a palliative care physician, and just has an interesting perspective on things. So if you get a chance, I follow him on Twitter as well, and he always has good things to say. But I thought this piece he just wrote for the New York Times was really appropriate for starting this discussion. And I'll just read through some of the little lines I got from that opinion article he wrote. No heartbeat and no breathing, which is obvious enough, or no brain function, which requires an EEG. And this was his What is Death? For some of us, death is reached when all other loved ones have perished, or when we can no longer think straight, or go to the bathroom by ourselves, or have some kind of sex, when we can no longer read a book or eat pizza, when our body can no longer live without the assistance of a machine, when there's absolutely nothing left to try. Maybe the most useful answer I ever came across was the brilliant professor who instructed his daughter that death was what happened when he could no longer take in a Red Sox game. So again, what is death? Talking about and around it may be the best we can do, and doing so out loud is finally welcome. Facts alone won't get you there. We're always left with the next biggest question, one that is answerable and more useful anyway. What is death to you? When do you know you're done? What are you living for in the meantime? We do have fuller ways of knowing. Who doubts that imagination and intuition and love hold power and capacity beyond what language can describe? You are a person with consciousness and emotions and ties. You live on in those you've touched in hearts and minds. You affect people. Just remember those who've died before you. There's your immortality. There in you they live. Maybe this force wanes over time, but it is never nothing. So I just think that he has beautiful words and just a neat way to think about things. And I think more than what he's talking about is what is death, is he's, I think, getting at what is living and what is quality of life to you. And I think that's kind of what we're digging at when we're talking to people about their advanced care plans and what matters most to them. It's kind of thinking about with what losses can you live, right? So he at 18 had to learn to live with a lot of losses, and so I think it's just a really neat piece, and I encourage you to go find it there and look at it. Another great piece that helps think about what we're talking about today in a different way is Being Mortal, the book by Atul Gawande, and he also has a frontline PBS you can find, and I think we put it at the end to a documentary from years ago. And in there he talks about two different people where what he got to kind of quality of life and what matters most to them. One thought it was worth living life as long as they could eat ice cream and watch, a baseball game. And another person, to them, it meant quality of life is if I can play tennis. If I can't play tennis anymore, then life is not worth living. So it just, I think, goes to show how it's different for all of us. Where do Americans die? Studies show time and time again that most of us, 80% of Americans, would prefer to die at home. If possible. But despite this, 60% of Americans die in acute care hospitals, 20% in nursing homes, and only 20% of us get to die at home. So a minority, very minority of dying patients use hospice care. And when those patients are referred, it's often, this says 3 to 4 weeks of life, but often it's even in the last days of life that we get them to hospice care. Not everybody wants to die at home, and it's our job to try to figure out, where and why, and how can we help whatever their wishes are come true, right? And sometimes that's cultural issues. A lot of times I find that that's because an experience they had when a loved one, like a grandparent, died at home and they happened to see them or find them or something. So often there's stories like that for people who prefer not to die at home. So we got to have those conversations. If we don't talk about it, how are we going to make it happen, right? But I think the big message here is that fewer people are dying where they want to die than we should allow, right? This should be our mission, is we should, we make birth plans. Why do we not focus on death plans as well? And so hopefully this helps you be as passionate about this as Marsha and I are, I think. Why are people dying in hospitals and not where they want to die? I think this is complex and multiple things go into this, but as the biggest reason, death is unpredictable. We don't know when we're going to die, right? Even when we know somebody's at their end of life, there's been studies, we do just a very poor job at being able to predict how long somebody actually has to live. So it's just unpredictable. There's an overestimation of the ability of medical care to cure incurable illness or reverse setbacks. And I think this one's huge. I mean, I think that's why, and one down below here, doctors may encourage patients to have inpatient treatment with little chance of changing the long-term outcome. perhaps due to an overly optimistic view of the prognosis and the culture of medicine and availability of medical care. So I think these are the reasons I became a geriatrician. You know, when I was in residency, internal medicine residency, I was at, you know, Barnes, huge university hospital, specialists, some of the best specialists in their fields were teaching me. And the culture is you find the problem and you fix it no matter what, right? And I often felt like we were doing so much to torture people, really, in the end of life, than help them have a good last few months. And it was the geriatricians that I saw in my training that had a different theory or idea about how we should look at the end of life and these situations. And really, it's almost doing a geriatric fellowship is almost an unlearning of some things, right? And so, but this is a big deal. We all the time are pushing and over treating because we aren't taught maybe another way to look at things, and I think we're doing better with that now. But because the whole culture is and not one to step back and think about what is this giving our patients. So now we're really with this IHI and age-friendly and patient-centered care is another thing that's going around. I think we're doing a better job at trying to involve patients' values and goals in what we do. And so that's really what advanced care planning helps us do. So I think if you ask most of us, me included, if I had to plan my death, I'd want to live functioning at my 20-year-old body with that much energy and physical ability, and just live as my 20-year-old self until all of a sudden I fell asleep and didn't wake up. And I think maybe for me that would be the age of 90 would be good. I'd say I'd like to live to 90 with a 20-year-old body and then just fall asleep and not wake up. But that's not the reality. Because of the advances that we have in the medical field, we keep people alive with multiple chronic diseases. There's the fifth M of geriatrics, and that's multimorbidity. And that's because we're keeping people alive who might have died, 20 years ago. That same person would have died with their heart attack and their heart failure that followed. But we're with the medicines and different technological advances, we're able to keep these people alive. And often there's lots of good years in how we keep them alive, but then this graph here kind of shows then another little thing happens. So we fall and we break our hip and we get knocked down a little bit, and then we get a pneumonia and we're in the hospital for a couple of weeks and we're knocked down a little bit more. And so we kind of just go through this stepwise decline. And something I read an article where 95% of us will spend the last 4 years of our life requiring help with at least one activity of daily living. So that's dressing, toileting, bathing, and eating are activities of daily living. So the majority of us will require help with at least one of those for the last 4 years of our life. So that's significant. And this talk isn't about that, but there's lots of things we can do to maybe change that, but that's a whole different talk. So we're talking about, this is why advanced care planning is important, because what quality are we getting in some of those years? Other reasons that advanced care planning are very important is that we're moving maybe from home to a hospital or to assisted living and a nursing home and home. And so care can be fragmented. We don't always get to see our primary care. We certainly aren't seeing our primary care in the hospitals anymore because we have hospitalists for that. So because you don't know your doctor who's going to care for you in the hospital is a different person than the one you have to have things in writing because we can't pass that along. If you had something happen and you couldn't speak for yourself, who's going to make decisions for you and say what your plan is and what your thoughts are on end of life and all these medical care decisions that you have? So you got to designate somebody to speak for you, or else your wishes are not going to happen if you have something like a stroke where you can't speak for yourself. And then I think another very good reason to talk about advanced care planning is the burden that these choices that family has to make, right? If you haven't made yourself clear what your choices are, then your family is having to make those choices for you. And that is a very stressful thing. It often, I mean, we see it all the time, just break families apart because of disagreements between, maybe the family who's been around and caring for mom, and then the sibling who comes in from across the country and is dealing with a lot of guilt and other things. And just that dynamic, there becomes a lot of stress on families, and it can be really devastating to families. So that's an important reason that we should think about and write down and discuss our advanced care plans with our families. And simply, if we don't document it and talk about it, it's not going to happen. So if you don't make your birth plan and your death plan, then just whatever happens is going to happen, right? You have no control over it. So those are the reasons why I think these conversations are very important. And so I'm going to let Marsha take over for a bit here and tell you the different types of documentations we have and how we make those and what they mean differently.
All right, thank you, Lindsey, for acknowledging all those issues and just moving this forward to make patients' end of life stories better and the importance of planning. I'm an advanced care planning facilitator, so I attended a certification course that has taught us how to have these conversations, how to complete documents, because most of us aren't born comfortable doing this. So I'll start just by taking this look at the different documents. We have the advanced directive, the post form, and the DNR order. And all important and all are necessary for the role that they play. The advanced directive, of course, is a legal document, and that's for anybody over the age of 18 for that what if situation. What if there was a car accident or they had a significant stroke? And in that document, because it's a legal document, they designate who they want to be their spokesperson, and we call that person a healthcare agent. And for a person to complete an advanced directive, they have to have capacity. Now, the post form, on the other hand, is an actual order. Excuse me. And the form is intended for people who are dealing with advanced illness, and they wouldn't be surprised if they were to pass in the next 1 to 2 years. It does not name a decision maker, and the patient does not require capacity to fill it out. It does require a provider's signature, and it's something that it's an enforcer. It has a little more teeth to it. And advanced directive kind of provides us that roadmap when the time comes. And with the DNR order, it's mentioned there because a lot of people will say, well, we talk about code status every time they come into the hospital, but what if they're not at the hospital? And that's the role that the post form plays, is allowing them that DNR status that they choose to be upheld. Of course, the DNR order doesn't determine who they want to be their decision maker, and it is only pertinent for that admission. It's a question we ask every time. So depending who's asking it, it can end up being fairly inconsistent. Okay, and am I able to change the slide? Okay. All right, and this is a sample of our post form that we have in North Dakota. And advanced care planning is a state-by-state initiative. So what the post form has tried to create is a national effort to bring consensus and to standardize the language and ultimately increase the chances of somebody's code status, excuse me, and end of life wishes being honored. And at the end of the PowerPoint is their website. They have a great site. And they do have a national post form, and as every state, you're going to see many names for the post form. In North Dakota and Minnesota, we go with post. South Dakota is most. You're going to see iPost in Iowa. There's 16 different names for it because some states just wanted to have their individuality. But anyway, a great need for it. And there's a lot of research that points to, people receiving concordant care when they have a post form on file. It's like 96%. And in the episodes where it hasn't been honored, it's usually been because it probably wasn't a healthcare agent that was had that skill set to serve in that role. All right, next one. And every organization is going to have its system and how they implement their process. And what you see now is going to be 3 slides from the advanced directive that we use, and it's probably identical to what you might see at about 165 organizations in our state follow the same formatting. So once we receive a referral, then we take this, we meet with that patient and, like Dr. Dahl said, do a deeper dig into what their perspective is on things. There's also the website at the end of the PowerPoint for Honoring Choices North Dakota, and that is who kind of brought this formatting forward. Honoring Choices Minnesota has really done a remarkable job in bringing this to 13 different states, so it lends that collaboration and that consistency in the conversation. So in our booklet, we have these questions we give them to reflect on. It just kind of primes the pump. So when they come in for that meeting, they understand some of these things. These are deep questions, and they warrant some thinking, pre-contemplative thinking. The second 2 of 9 page there is where we help them select their healthcare agent. I won't go into a lot of details, but we just kind of want you to see the formatting of our form. So we encourage them to select a primary and an alternate. Next page. All right, and this is a little more on the healthcare agent, things we discern where we can make that a durable power of attorney. If I dare say, there's really no reason a person has to go to an attorney or spend money to have these forms done. We are, as long as this form is notarized, it stands the test of what the medical community is looking for to help honor their wishes. And then the medical questions we move in to talk about is CPR. And what if you had that severe permanent brain injury? And it really isn't, we could check these boxes and be done with the form in 30 seconds, but we spend most of our time trying to educate them and really get them to pull out, what are their goals for care and what is their understanding about what all goes into that. So yes, it's talking about CPR. And then on the next page, Dr. Dahl, is where we talk about if you had that severe permanent brain injury, what would you want? Would you want treatment stopped or withheld, or all treatments recommended? And again, it goes into a much deeper conversation, but this is where we transcribe their decisions to. This is a beautifully comprehensive document. We ask about organ donation, autopsy, because we know those are questions families are going to be asked. And most of these questions are based on things that families have told us not knowing really created a hardship for them. But you can see on page 7 to 9, that's where we start this. Everything in the document is really about what matters most to them. But this starts with that question, the things that make life most worth living. And you really come at that at so many different angles until the light bulb kind of goes on, where they just like, okay, I get that. And so what is a good day to you? Who would you be with? What would you be doing? What brings you joy? And it just brings a lot of clarity to their life. And I think it's so ironical because when you first sit down with people and you start with what they think might be a little touchy-feely, that quickly fades. I think once they realize that this time to reflect is valuable for them, but this gives us somewhere to turn to say, how would their quality of life be impacted if we can see these things that matter to them are going to be affected? And then we switch it to, you know, at what point would life no longer be worth living? And that looks different for everybody. There's no right or wrong answers, but it's just to know what sits in their heart and allow them to articulate that. We talk about medical treatments. We ask them where they would like to die and how they envision that time, what would be important to them, because then that allows them that time to plan and put their affairs in order to allow that to happen. We ask about religious background, cultural, spiritual beliefs, because that has a big impact on how people view end of life. And so that is part of it. And then we touch on funeral. You know, it's just one more place to put if their wishes towards cremation, or do they want a service? Do they want to be buried? So it just, like I said, we don't want this to be to the end of their planning. We hope it's the beginning, that it just starts to open up conversations and really normalizes this as a part of good healthcare and things we want to know to better take care of them. Okay, next one. All right. Did you want to?
Yeah, I think we did want to briefly talk about maybe some times when we didn't have an advanced care plan, and maybe how that looked and how it went and why. And I was thinking about one, so I'll go first, Marsha, and you can maybe add one after. And it's not necessarily death, but I remember one of my patients came to see me after she'd been hospitalized, and it was kind of an out of nowhere hospitalization where her kidneys ended up failing because of the treatment or the illness or whatever, and she had to be started on dialysis, and she was in her 90s. And I remember seeing her in a hospital follow-up, and she had the temporary ports for dialysis, and she was scheduled. And so this post-hospital follow-up was also to be a pre-op for a fistula formation for her chronic dialysis at the age of 93. And I remember just looking at her, and, you know, she had the deer in the headlights kind of look. And I said, you do know that you have some choices here, that you don't have to have dialysis. And she just started crying. It was like she just needed somebody to say, you have a different choice, that's not your only choice. And so then we talked about then, you know what, but I think that's a place we probably didn't have a very good advanced care plan in, or if we did, nobody looked at it. And when they presented dialysis to her, you know, in the way that I've probably done and am guilty of, we stood at their bedside and said, you know, you have to have dialysis. And that we didn't give them an option. And she just started crying, and she said, nobody gave me a choice. They didn't say I had a choice. Well, if you present the option as you get dialysis or you die, then there is no choice, right? And so we talked about what was the other choice, and she chose not to get the fistula and to stop dialysis, and had kind of some good times left with her family. But that was one, and I'm sure we all have lots of examples of this, but do you want to share one, Marsha?
I unfortunately have a lot of examples, but I'm just going to share a couple that have just really resonated recently. There was a gentleman that I had been trying to get in touch with. His provider wanted him to do advanced care planning because he was very ill. And 10, 12 times we couldn't get things to connect, but it was a hill I was going to die on. And ironically, one day my phone rang and it was him, and he was in the hospital, and he's like, yeah, Marsha, do you have time to get up here? I want to get this form filled out. And when I got there, he told me, he said, they're going to make me go to a nursing home. And he said, and he was just that kind of guy. He's like, I'd rather be dead than do that. And they're not listening to me. And so we went through his directive. In the time I was there, a provider came through, and I said, I'm just helping with advanced care planning. And she came back later after I had left and asked him what that was about. And he told her, and she was the first person who listened to him and picked up on that. And that afternoon he went into hospice care, and he got to go home to his trailer in a bed in front of his TV with his dog and a couple of friends who offered to take care of him. And he passed 6 days later. And I just smile every time I think about him, because what mattered most to him wasn't what was mattering most to us. And there was that need to get rid of our biases when it comes to that. And then my one other situation just recently was a gentleman very, very ill, and had gone to 4 different nursing homes, and before he finally went to a nursing home in his hometown, and wanted to just go with comfort cares. And he got short of breath one day. His brother was there. He demanded he go to the emergency room. At the emergency room, he demanded that he come to a regional facility, where he ended up intubated in the ICU. And a week later, his wife asked them to remove it, and he went home and wasn't even home 4 hours before he passed. And I just feel like that was just such a failure on so many levels, that could we have advocated better? And when we talk about advanced care planning and the quadruple aim and the effect on cost, that isn't what it's about. But boy, did we miss the mark on that one, and left the wife really to have some difficult grief journey because of what went on. So
yes, thank you for sharing. I am sure we all can think about those patients and those times that kind of break our heart. So how do we get better at having these conversations? And I think in that advanced care plan booklet, there's definitely good questions to ask. And I kind of always start, I just kind of say at the end of my visit with a patient, I say, and I really don't have a lot of time, so I have to try to, it's different visits. I kind of scratch the surface at the start, and then I try to dig a little deeper. But the first question I ask, I've been asking everybody, what matters most to you? What makes life worth living? And generally they, scratch, they say, oh, my family and my health and my friends, right? And so oftentimes you have to really start digging. So the next question I generally ask is, what brings you joy in each day? And so that becomes more difficult, right? Because it's not that you get to hang out with your daughter or grandkids every day. So what brings you joy in each day? And sometimes, we have to then dig a little bit deeper. What are you willing to live without and still feel that life is worth living? And what are your biggest fears and concerns? And often I think we take for granted, being in the medical field, what people understand about what we can do in medicine. And I think CPR is a perfect example of that. What you see in the movies is not reality. And so often there was a study where they asked people what their co-status was. And so, something like 80% said, yes, I went CPR. And then they showed them a 3-minute video of an actual CPR event. And then it went down to 30% who actually chose CPR after they saw a true CPR event. And so I'm on it. You got to be honest with people and describe, what is that truly like? We break bones if we're doing it correctly. And the reality is, even the best circumstances, CPR, in a nursing home, there's like 15% chance that we'll get your heart back, but less than 3% chance that you're going to walk away just as you went in, right? So you're going to take a hit to the brain. So I try to talk about what is the reality of that. What do you understand of your current health condition? What is the reality of what we can do with that and how we can fix that? I think we really oftentimes just don't understand how much a layperson doesn't get about health, right? Or about the things that we can and cannot do with medicine. And so it's our job to educate them about that. This is what I know. What do you understand? This is what I know and what I understand. And I think another important thing when talking about these things is you're often the one with the medical knowledge and they're not. So we have to understand their goals and values, and then we have to be the one that then says, well, this is what that means you want in my eyes, right? So I think this is what's going to get you support your goals and values is by doing this or by not doing that, right? So I think a lot of times, you know, they come in, we say, do you want DNR, are you DNR, DNI, or do you want full code? And we say, that's how you say it. And so do you want us to restart your heart? I'm always honest, you know, when your heart has stopped, you are dead. And we are trying to bring you back to life of some kind, right? So I think you have to be honest and choose your words wisely. And then ultimately it is up to the providers or the caretakers to say, to get you that goal or to get you to the place you want to be, we need to not do this procedure then, right? And so that's the part that's hard, and we're trying to educate providers about, right? Is taking a step back and saying, how are we aligning this? Is this aligning correctly? Are we doing way more than they're wanting? So I don't know if you have some other tips or ideas to share on this slide.
One of the things just to make you aware, you know, there's tools out there when you're having these hard conversations, and for instance, we have decision-making aids, you know, if they're trying to make decisions on CPR, and you feel like something like that would help. There's one for breathing and one for nutrition and hydration. And there's even some out there for dementia, which is another one that sooner than later, we should start those conversations.
And I think the obvious is, you know, when you're having these conversations, you should sit at eye level and make sure you're in a quiet room without distractions. And so often, if it's in an urgent situation, it's a doctor or somebody at the bedside standing above them, being the scary authoritarian in a white coat that says, you know, what do you want, this or that, live or die, you know? So we have to be careful. We need to sit down next to them at eye level. And I think, you know, humans are tactile people. I always, you know, touch them, touch their arm, let them know that I do care about them and that this matters to me like it matters to you. So I think it's important to think about the way in which you're delivering this information. So, Marsha, do you have any examples of times that things went well and wishes were followed?
I think my one was, you know, with my my friend who went back to his trailer with his buddies, and I want to touch on one of the things you were mentioning, you know, how important trust is. People have a lot of fears and concerns about advanced care planning. They sometimes fear we're trying to talk them into care. So it really is a time to build trust and meet them where they're at. I could briefly share my one example. My parents passed away in June, and they had both completed advanced directives. And so I knew this professionally, you know, the importance of it, but to learn it personally, I felt like I needed to call up every person I had ever helped in the past, because I don't feel like I could have given them the understanding they deserved, not having walked that walk. But with my dad, we had a direct conversation about, if you get COVID, would you want to be intubated? And because previously he had said, I would go on a ventilator for 3 days, but after that, and so we had that direct conversation with my mother. She had the beginning stages of Alzheimer's, and we sat down and had our conversation probably a month before she wouldn't have been able to do it anymore. And they both got COVID and they died 3 days apart. And when they called and were taking my dad to the emergency room, I didn't even have to think. I knew exactly what we were going to do. It was going to be exactly what he wanted done. And the same for my mother too. She made it very clear. When she was, starting to struggle with her disease, she did not want anything that would prolong her suffering. So are they perfect? No, never. But boy, did it greatly impacted how we can grieve and move on from that.
Yes, thank you for sharing that. And does anybody have any examples of patient situations, good or bad, that they would like to share with us?
Hi, everybody. Thank you for the opportunity to speak. I've spent 30 years in the trauma intensive care unit, and I'm always surprised, but I've probably over the 30 years had 100 patients who were in their 90s and their children were in their 70s. And you try to tell them that it's the end of the line, and they were like, well, they were good yesterday or the day before. But and I several times I've just asked them, well, how long did you expect them to live? And really you can see the light come on in their eyes. Are like, oh my gosh, they're 90s, whatever, and oh, my mom's really gonna die. Well, yeah, someday, so I just don't think that we as a culture think about death adequately. And I think that's why we don't die well in this country,
Oh, I totally agree. As a geriatrician, it still blows my mind when I'm talking with a 90-year-old and they seem to have never thought about death being imminent. And I'm always like, well, the average lifespan is still 76, 78. So you've outlived it by, 20 some years. Yet it's still a surprise to them that they should think about it in any way. So that's true. Our culture is just not one to think about that.
Yeah, we're not there at all. And then one thing that one scenario that I use with patients' families, because we inevitably are going to hit this 9 times out of 10, is I just tell them, we are divinely created by the Creator, whomever that is, to expire. And, death is a perfectly natural process, just like when you're born. And then that seems to make more sense to them, that this is a natural occurrence. It's very hard. It's very hard.
It is. I have a grandmother who's 106 years old, and sometimes she'll say, I don't know why I'm here, and I wish I wasn't. And then the next day, yes, I'd go to the hospital if I got sick. So even she struggles with it at 106, which part of that is, you have to have that positive outlook to live and be successful at life, right? But at some point you have to be realistic too. So I think there's a fine line there, right? Where we're hopeful and how do you bring someone to that point where they're still living but okay with death, right? It's tough conversations. The last little bit I want to get into before we can do some more sharing is kind of what is digging deeper into what matters most. Because I think as far as geriatrics and patient preferences and aligning care with what matters most, it's more than an advanced care plan. It's how we're treating them day to day. So I think the best way I've found to explain what this is to talk about two of my favorite patients. You know, they were both very similar in their 80s, congestive heart failure, COPD. One was having GI bleeds and the other was dealing with diabetes, but very similar, in and out of the hospital the last 6 months. We've had good conversations, and they both didn't want to do aggressive things. They were DNR, you know, but seeing them both at different times for hospital follow-ups. My one guy, you know, I'm asking what matters most to you and digging deeper. And he says, you know what? I need to live 2 years, because in 2 years, my grandson comes back from Japan and I want to see him again in person. So I've got to live 2 years. And so what mattered to him, he didn't care on a day-to-day basis what he felt like necessarily, as long as whatever we were doing was going to get him maybe closer to that 2 years. And so he was realistic. He said, you know I don't want to go through CPR. I don't want to be intubated. I wouldn't survive those things. That would be, he didn't even want a colonoscopy, even though he's having these GI bleeds, but he wanted, by golly, us to do everything we could, ramp up those heart failure meds, make my blood pressure low. I'll just lay in bed if I could get 2 years to see my grandson again. And so that was really what mattered to him. And in contrast, my other guy was around the same time, and I saw him for hospital follow-up, also for COPD, or a congestive heart failure exacerbation. And they ramped up all his meds like we do his for heart failure. And he said, you know what matters to me is playing cards with my buddies 2 days a week. And right now I can't stay awake. I just have no energy, and I just want to be able to play cards with my buddies. And so in that instance, right, he didn't care if he was on the meds that would give him more days and more days. He just wanted the days that he was here to feel good, to play cards. And so we came down on a bunch of his heart failure medications so that he had the energy to do that. And so he knew that maybe that meant he wasn't going to live as long, but that didn't matter, because he was going to be able to play cards with his buddies. So I think, it goes beyond advanced care plans, and goes to how we're treating patients every day. And so we have to try to dig into what matters to our patients, and be doing the things for them and with them each time we see them, to try to get them the best days that they have, whatever it may be left, right? Here's just a listen. We have the Honoring Choices, North Dakota. There's a Center to Advance Palliative Care, which has good information on it. The Conversations Project, I think Marsha's worked with a lot, and they have good information. The Institute for Healthcare Improvement has lots of toolkits and conversation pieces to help you, guide you through these conversations in a way to have them. And so, we're open to questions, comments. And Marsha, I don't know if you have any last comments to make.
I was just going to make a comment on Honoring Choices, that you can always attain forms from their website. They have the Advanced Directive and Pulse forms. And they also offer a lot of it. Nancy Joyner from UND, and she's done wonderful work trying to bring more literacy to advanced care planning, but really the Pulse form. So there's an opportunity to take classes from that site also.
Dr. Dahl, did your patient live for 2 years to see her grandson or his grandson?
No, he did not, unfortunately, but I hope we had, and I never did find out if he came home to see him, but they were planning on that, because we knew that he wasn't quite going to make it.
Ugh.
Yeah.
So there is some discussion in the chat about just kind of the cultural differences and different things, for Gunjan had brought up India, and people are bringing up, Native American cultures. Do you guys have any specific recommendations or ideas on how to maybe address those as they come up?
I think it's just having those conversations to figure out, what matters to them, and understanding why. I don't know specifically, some of the cultural things I know, but I think it's, in your best interest to learn about those things if you're dealing with a patient and trying to help them navigate through, certainly.
I had an experience with in my hospice rotation with a young man, I believe he was Hmong, whose family did not want him to die at home, so he was in the hospice house, but they have an elaborate death ritual, and which involves dressing him in several layers of clothes, and burning strips of paper immediately as the soul leaves the body. And so it was amazing. The chaplain and the people at hospice house worked with them to enable that to happen, at least in some way. And that kind of thing too, to be taken into account, because it was kind of a scramble. He didn't live long in hospice house, and they'd actually didn't know this was all an issue until they came in carrying a big iron cauldron to burn stuff in. And they're like, oh, why did you bring that? And that's how they found out. So then they quickly put it together. But that'd be an interesting thing, especially if you get into these conversations, maybe with people from other religions, if there's any sort of ritual that needs to be done.
And we do have a question in the chat. Is there a shift happening in healthcare where general healthcare or physicians will welcome the help of hospice earlier?
I think so. I mean, we're trying. There's lots of conversations now between me and there's and advanced care planning groups, and but there's a long ways to go, I think, but we're trying. I don't know, Marsha, what do you see in the hospital?
Yeah, I would say, I mean, this kind of shifting culture is not easy, but I think there's just, I refer to it as the architect of healthcare. When you look at this movement towards patient-centered care, I mean, advanced care planning delivers on that. And society, everything they're reading talks about advanced care planning and the importance of it. So they're coming to us and they're going to be the ask. And we need to be there ready to go, and not just to help them get a directive on file, but how are we working to guarantee them, you know, it's a promise we make to them that we will honor, you know, their wishes. And there are wrongful life suits going on all over the country because that's not happening. So I think we're going to see a lot more attention and efforts to honor these documents.
I have a question. Do you think, this is Shelley, do you think that the aging services would ever consider doing like you know, we have more elderly people, or even, you know, it's people in their 50s on up. Would they ever consider doing some sort of a outreach or a Zoom call for your community, you think? You know, if you were going to have an event, so it isn't you necessarily as the healthcare system doing it, but you have a resource to provide that whole document that you had as far as advanced planning. You know, so it's an agency helping the facility, because it takes a lot to put all that together, you know?
Yeah, I know that the AARP does things on a regular basis, that they try to get the word out in education, and I think they do some things like that that would be considered outside of the medical field.
Yeah, I know there's all that. I mean, it comes back to the aging friendly communities. I mean, there are so many resources on ARP. I've come across them. So thank you for mentioning that.